Hey everyone, welcome! If you're prepping for your MRCOG exams, you're in exactly the right place. Today we're going through a high-yield, purely evidence-based explainer of the RCOG Green-top Guideline 20a on external cephalic version, or ECV. Look, this is an absolutely critical topic for your exams. It's just packed with specific grading recommendations and clinical statistics that you simply have to know cold. Our goal today is to give you the full details of the whole guideline, breaking it down fact by fact, so you know exactly what to remember to succeed. So let's get into it.
Okay, let's dive right into our roadmap. We're going to cover 5 main buckets today. Section 1 is the effectiveness of ECV. Section 2 is timing and patient selection. Section 3 covers improving ECV success. Section 4 is all about risks and fetal monitoring. And finally, Section 5 goes over non-ECV alternative methods.
All right, kicking things off with Section 1, effectiveness of ECV.
So, to really ground our clinical discussion today, let's just make sure we're being super precise. External cephalic version, or ECV, is formally defined as the manipulation of the fetus through the maternal abdomen to a cephalic presentation. Basically, it's our primary mechanical intervention to correct breech presentations. The whole point here is preventing a non-cephalic birth and completely avoiding the long-term sequelae that come with a cesarean section.
Okay, locked this number into your memory right now. 50%. As a grade A recommendation, women absolutely must be informed that the overall success rate of an ECV attempt is approximately 50%. Whenever you get a counseling question on the exam, this 50% mark is your baseline anchor.
Now, the really crucial point here is what actually happens after the procedure. First off, if an ECV is unsuccessful at 36 weeks or later, only 3 to 7% of those babies are going to spontaneously turn cephalic. Do not let exam distractors trick you into reassuring a patient that spontaneous version is highly likely. It's just not. On the flip side, if the ECV is successful, it's incredibly rare for the baby to revert back to breech. We're talking only about 3% of cases. Recognizing these exact percentages is precisely how you'll need to counsel patients on expectations versus reality on the wards. Now, both of those post-ECV realities are grade B recommendations, and absolutely crucial to remember as a grade A recommendation, a successful ECV significantly reduces the overall chance of a cesarean section.
Moving right along, let's get into Section 2, timing and patient selection. You absolutely have to know the distinction between nulliparous and multiparous women for the MRCOG. It's a classic test point. For nulliparous women, ECV may be offered from 36 plus 0 weeks of gestation. That's largely because they have a lower overall success rate, about 40%, and spontaneous version is much less likely. For multiparous women, however, the guideline specifically states ECV should be offered at term, from 37 plus 0 weeks. That's a grade B recommendation. Their success rate is much higher, sitting right around 60%. And, this higher success rate makes sense when you think about it. It's largely due to the relaxed uterine tone and abdominal musculature from their previous pregnancies, which just makes manipulation easier.
Now, beyond parity, there are a few specific clinical predictors of success that you're going to need to spot in clinical vignette questions. Multiparity is a strong predictor, sure, but look at the odds ratios here. Non-engagement of the breech gives an odds ratio of 9.4, but then look at the use of tocolysis, an absolutely massive predictor with an odds ratio of 18. That is a sheer clinical advantage you simply cannot overlook. Having a palpable fetal head and a maternal weight of less than 65 kilograms are also key predictors. When a question asks you to evaluate the likelihood of success based on a patient's characteristics, these are the exact variables you'll be looking for.
Which brings us nicely to Section 3, improving ECV success.
This next part is great because it perfectly illustrates the pharmacological hierarchy you need to master. Tocolysis, specifically using beta-mimetics, is your gold standard grade A recommendation. It definitively improves success rates and it reduces cesarean sections. Routine use is completely supported here. On the other hand, look at regional analgesia or neuraxial block. This is a grade B recommendation, but note the application carefully. It is absolutely not for routine use. You should only select regional analgesia on the exam for a repeat attempt or if the woman is just totally unable to tolerate the procedure because of the pain.
So if you do choose tocolysis, the pragmatic regimens endorsed by the guideline are 250 micrograms of salbutamol by slow intravenous injection or 250 micrograms of terbutaline subcutaneously. But hey, be careful here. You must screen your patients. Beta-mimetics are strictly contraindicated in women with significant cardiac disease or hypertension. They're also going to be completely ineffective if the patient happens to be taking beta blockers simply due to the direct pharmacological antagonism at the receptor level. Make sure you keep those safety caveats locked in for the exam.
All right, let's pivot over to Section 4, Risks and Fetal Monitoring.
Now, what's really interesting about this next point is how the guideline completely busts a super common clinical myth. ECV after one cesarean delivery appears to have no greater risk than with an unscarred uterus. This is a grade C recommendation. You know, a lot of candidates incorrectly assume a previous C-section is an absolute contraindication, but the data actually shows it's safe and successful in women with one previous C-section, with literally no reported uterine ruptures in the analyzed cohorts.
Of course, women are naturally going to ask you about the risks to their baby, and you need to be deeply reassuring while staying completely factual. The risk of actually needing an emergency cesarean section within 24 hours of an ECV attempt is incredibly low. We are talking less than 0.5%. And when it does happen, the indication is usually vaginal bleeding or an abnormal CTG following the procedure. The main takeaway to emphasize to patients here is that the risk of a true emergency is exceptionally rare.
That being said, ECV is definitely not for everyone. You've got to memorize these absolute contraindications for the patient's safety questions. Do not attempt an ECV if there's already an absolute indication for a C-section, like placenta previa, for example. It's also contraindicated in multiple pregnancies, with the one tricky exception being right after the delivery of a first twin. Rhesus isoimmunization and recent vaginal bleeding within the last week, those are hard stops. And think about the clinical rationale for a second. Ruptured membranes are an absolute contraindication because there is simply no amniotic fluid buffer left to facilitate the physical turn. Finally, any abnormal electronic fetal monitoring means you absolutely do not proceed. Period.
Okay, so once the procedure is done, whether it was successful or not, there's a mandatory safety checklist you have to run through. Step 1. Continuous electronic fetal monitoring is recommended to confirm a normal fetal heart rate. Now, transient bradycardia is pretty common, but if it persists beyond 6 minutes, you prep for a Category I C-section. Step 2, assess the patient for any vaginal bleeding or unexplained abdominal pain. Step 3, for D-negative women, testing for fetal-maternal hemorrhage via a Kleihauer test and offering anti-D as a strict grade D recommendation. Remember that grading level, too, because exams love to test the specific grades of post-procedure protocols.
And finally, we've made it to Section 5, non-ECV alternative methods. You know, patients are definitely going to ask you about alternative therapies. And here's the strict evidence-based stance you need to take. Moxibustion actually has a grade C recommendation, so women may consider using it at 33 to 35 weeks under trained guidance, as some studies do suggest it increases cephalic presentation. However, postural management, which is having the mother adopt specific physical positions, like the knee chest position, is a completely different story. The guideline provides a grade B recommendation firmly against it. There is literally zero evidence that postural management alone promotes spontaneous version, so you absolutely should not advise it in clinical practice. As we wrap up this explainer, I want to leave you with a really crucial thought regarding your everyday clinical practice. The guideline makes a point to note that the single greatest impediment to ECV is simply missing the diagnosis of breech presentation entirely. With undetected term breech presentation sitting as incredibly high as 20 to 32%, how are you going to adjust your clinical palpation and ultrasound referrals to ensure every eligible woman is actually offered an ECV? It's a huge challenge to take with you into the wards. Thank you so much for joining me to master this guideline. Keep studying hard, and I'll catch you in the next one.